Hello friends, welcome to the Green Top Guidelines Summary of the Day. Today we are here to talk about the placenta previa and the placenta accreta, the diagnosis and management. The Green Top Guideline 27A, published in September 2018. Placenta previa and placenta accreta are associated with high maternal and neonatal morbidity and mortality. The rates of placenta previa and accreta have increased and will continue to do so as a result of rising rates of cesarean deliveries, increased maternal age, and use of assisted reproductive technology, placing greater demands on maternity-related resources. The purpose of this guideline is to describe the diagnostic modalities and review the evidence-based approach to the clinical management of pregnancies complicated by placenta previa and placenta accreta. Placenta previa was originally defined using the trans-abdominal scan as a placenta developing within the lower uterine segment and created according to the relationship or the distance between the lower placental edge and the internal os of the uterine cervix. The placenta accreta is the histopathological term first defined by Irving and Hertig back in 1937 as the abnormal adherence of the afterbirth in whole or in parts to the underlying uterine wall in the partial or complete absence of the decidua. Cesarean delivery is associated with an increased risk of placenta previa in subsequent pregnancies. This risk rises as the number of prior cesarean sections increases. Assisted reproductive technology and maternal smoking increase the risk of placenta previa. The mid-pregnancy routine fetal anomaly scan should include the placenta localization, thereby identifying the women at risk of persisting placenta previa or a low-lying placenta. If the placenta is thought to be low-lying, less than 20 mm from the internal os or previa covering the os, at the routine fetal anomaly scan, a follow-up ultrasound examination including a TVS is recommended at 32 weeks of gestation to diagnose persistent low-lying placenta or placenta previa. The term placenta previa should be used when the placenta lies directly over the internal os for pregnancies at more than 16 weeks of gestation. The term low-lying placenta should be used when the placental edge is less than 20 mm from the internal os on the transabdominal or transvaginal scanning. Clinicians should be aware that transvaginal scan for the diagnosis of placenta previa or a low-lying placenta is superior to transabdominal and transperineal approach and is safe. In women with a persistent low-lying placenta or placenta previa at 32 weeks of gestation who remain asymptomatic. An additional TVS is recommended at around 36 weeks of gestation to inform discussion about mode of delivery, a very important exam question. A short cervical length of TVS before 34 weeks of gestation increases the risk of preterm emergency delivery and massive hemorrhage at cesarean section. Tailor the antenatal care, including hospitalization to individual women's need and social circumstances. Example, distance between the home and the hospital and availability of transportation, previous bleeding episodes, hematology laboratory results, and acceptance of receiving donor blood or blood products. It should be made clear to any woman being treated at home in the third trimester that she should attend the hospital immediately if she experiences any bleeding, including spotting, contractions, or pain, including vague suprapubic period like aches. Where hospital admission has been decided, an assessment of the risk factors for venous thromboembolism in pregnancy should be performed as outlined in the Royal College as Green Top Guideline 37A tells us. Women with asymptomatic placenta previa or a low-lying placenta in the third trimester should be counseled about the risk of the preterm delivery and obstetric hemorrhage, and their care should be tailored to their individual needs. Women with asymptomatic placenta previa confirmed at 32 weeks follow-up scans and managed at home should be encouraged to ensure they have safety precautions in place, including having someone available to help them as necessary and ready access to the hospital. The use of the cervical circula to reduce the bleeding and prolonged pregnancy is not supported by sufficient evidence to recommend its use outside of clinical trial. A single course of antenatal corticosteroid therapy is recommended between 34 and 35 plus 6 weeks of gestation for pregnant women with a low-lying placenta or placenta previa, and is appropriate prior to 34 weeks of gestation in women at high risk of preterm birth. Tocolysis for women presenting with symptomatic placenta previa or a low-lying placenta may be considered for 48 hours to facilitate administration of antenatal corticosteroids. The late preterm, that is 34 to 36 weeks of gestation, delivery should be considered for women presenting with placenta previa or low-lying placenta and a history of vaginal bleeding or other associated risk factors for preterm delivery. Delivery timing should be tailored according to antenatal symptoms, and for women presenting with uncomplicated placenta previa, delivery should be considered between 36 and 37 weeks of gestation. In women with a third trimester asymptomatic low-lying placenta, the mode of delivery should be based on the clinical background, the women's preferences, and supplemented by ultrasound findings, including the distance between the placental edge and the fetal head position relative to the leading edge of the placenta on TVS. Prior to delivery, all women with placenta previa and their partners should have a discussion regarding delivery. Indications for blood transfusion, hysterectomy should be reviewed, and any plans to decline the bladder blood products should be discussed openly and documented. The placenta previa and anterior low-lying placenta carry a higher risk of massive obstetric hemorrhage and hysterectomy. Delivery should be arranged in a maternity unit with on-site blood transfusion services and access to the critical care. Women with atypical antibodies form a particularly high-risk group, and the care of these women should involve discussions with the local hematologist in the blood bank. Prevention and treatment of anemia during the antenatal period is recommended for women with placenta previa or a low-lying placenta, as for any pregnant women. Women with atypical antibodies form a particularly high-risk group, and the care of these women should involve discussions with the local hematologist and the blood bank. Prevention and treatment of anemia during the antenatal period is recommended for women with placenta previa or low-lying placenta, as for any pregnant women. As a minimum requirement for a planned cesarean section for a woman with placenta previa, the surgical procedure should be carried out by an appropriately experienced operator. In case of planned cesarean sections for placenta previa or a low-lying placenta, a senior obstetrician and a senior anesthetist should be present within the delivery or theater suite where the surgery is occurring. When an emergency arises, the senior obstetrician and senior anesthetist should be alerted immediately and attend urgently. Regional anesthesia is considered safe and is associated with lower risks of hemorrhage than general anesthesia for cesarean delivery in women with placenta previa or low-lying placenta. Women with anterior placenta previa or a low-lying placenta should be advised that it may be necessary to convert to general anesthesia if required and asked to consent. Close liaison with the hospital transfusion laboratory is essential for women presenting with placenta previa or a low-lying placenta. Rapid infusion and fluid warming devices should be immediately available. Cell salvage is recommended for women where the anticipated blood loss is great enough to induce anemia, in particular in women who would decline the blood products. Consider a vertical skin or a uterine incision when the fetus is in a transverse lie to avoid the placenta, particularly below 28 weeks of gestation. Consider using the preoperative and intraoperative ultrasonography to precisely determine the placental location and the optimal place for uterine incision. If the placenta is transected during the uterine incision, immediately clamp the umbilical cord after fetal delivery to avoid the excessive fetal blood loss. If pharmacological measures fail to control the hemorrhage, initiate intrauterine tamponade or surgical hemostatic techniques sooner rather than later. Interventional radiological techniques should also be urgently employed where possible. Early recourse to hysterectomy is recommended if conservative medical or surgical interventions may prove ineffective. The major risk factors for placenta accreta spectrum are history of accreta in a previous pregnancy, the previous cesarean delivery, and other uterine surgeries, including the repeated endometrial curettage. This risk rises as the number of prior cesarean sections increase. Women requesting elective cesarean delivery for non-medical indications should be informed of the risk of placenta accreta spectrum and its consequences for the subsequent pregnancies. Antenatal diagnosis of placenta accreta spectrum is crucial in planning its management and has been shown to reduce the maternal morbidity and mortality. Previous cesarean delivery and the presence of an anterior low-lying placenta or placenta previa should alert the antenatal care team of the high risk of placenta accreta spectrum. Ultrasound imaging is highly accurate. When performed by a skilled operator with experience in diagnosing placenta accreta spectrum, refer women with any ultrasound features suggestive of placenta accreta spectrum to a specialist unit with an imaging expertise. Women with a history of previous cesarean section seen to have an anterior low-lying placenta or placenta previa at the routine fetal anomaly scan should be specifically screened for placenta accreta spectrum. The diagnostic value of MRI as compared to the ultrasound is secondary. However, MRI may be used to complement the ultrasound imaging to assess the depth of invasion and the lateral extension of the myometrial invasion, especially with the posterior placentation or in women with ultrasound signs, suggesting the parametrial invasion. A very important exam question: when to choose TVS, when to choose MRI. MDT is required for the treatment of morbidly adherent placenta. It should take place in a specialist center with logistic support for immediate access to the blood products, adult intensive care unit, neonatal intensive care unit by a multidisciplinary team. Expertise in the pelvic surgery is required. The delivery plan with a placenta accreta spectrum in the absence of the risk factors would be 35 to 36 plus 6 weeks of gestation, providing the best balance between the fetal maturity and the risk of unscheduled delivery. Once the diagnosis of placenta accreta spectrum is made, a contingency plan for emergency delivery should be developed in partnership with the women, including the use of an institutional protocol for the management of maternal hemorrhage. Once the diagnosis of placenta accreta spectrum is made, a contingency plan for emergency delivery should be developed in partnership with the women, including the use of an institutional protocol for the management of maternal hemorrhage. Any women giving consent for cesarean section should understand the risk associated with cesarean section in general and the specific risks of placenta accreta spectrum in terms of massive obstetric hemorrhage, increased risk of lower uterine tract damage, the need for the blood transfusion, additional possible interventions in the case of the massive hemorrhage should also be discussed. The elective delivery of women with placenta accreta spectrum should be managed by a multidisciplinary team, which should include the senior anesthetist, obstetrician, and gynecologist with appropriate experience in managing the condition and other surgical specialties if indicated. In an emergency, the most senior clinician available should be involved. The choice of anesthesia depends upon the anesthetist conducting the procedure in consultation. The women should be informed that the surgical procedure can be performed safely with regional anesthesia, but should be advised that it may be necessary to convert the general anesthesia if required and asked to consent to this. Cesarean section hysterectomy with the placenta left in situ is preferable to attempt to separate it from the uterine wall. When the extent of the placenta accreta is limited in depth and surface area, and the entire placental implantation area is accessible and visualized, now, in this situation, uterine preserving surgery may be appropriate, including a partial myometrial resection. The uterus preserving surgical techniques should only be attempted by surgeons working in teams with an appropriate expertise to manage such cases. There are currently insufficient data to recommend the routine use of the ureteric stents in the placenta accreta spectrum, but the use of the stents may have a role when the urinary bladder is invaded by the placental tissue. However, we have limited evidence to support the uterus preserving surgeries in placenta accreta, and women should be informed of the high risk of peripartum and secondary complications, including the need for the secondary hysterectomy. Elective peripartum hysterectomy may be unacceptable to women desiring uterine preservation or considered inappropriate by the surgical team. In such cases, leaving the placenta in situ should be considered. When the placenta is left in situ, local arrangements need to be made to ensure regular review, ultrasound examination, and access to the emergency care should the women be experiencing complications such as bleeding or infection. Methotrexate adjuvant therapy should not be used for expectant management as it is of unproven benefit and has significant adverse effect. The largest studies are necessary to determine the safety and efficacy of interventional radiology before this technique can be advised in the routine management of placenta accreta spectrum. Women diagnosed with placenta accreta spectrum who decline the donor blood transfusions should be cared for in a unit with an interventional radiology service. If at the time of an elective repeat cesarean section, where both the mother and the baby are stable, it is immediately apparent that placenta accreta is present, an opening of the abdomen, the cesarean section should be delayed until the appropriate staff and resources have been assembled and adequate blood products are available. This is your exam extended batch question. This may involve the closure of the maternal abdomen and urgent transfer to a specialist unit as well. In case of unsuspected placenta accreta spectrum diagnosed after the birth of the baby, the placenta should be left in situ and an emergency hysterectomy should be performed. A very important algorithm from the Green Top guideline and Appendix 3 with an ultrasonographic imaging signs, which are commonly used. So what are the important exam points from this Green Top guideline? Friends, you all should be well versed with the classification of the placenta previa, the care bundle plan of the placenta previa and the placenta accreta. What are the investigations of choice, including when to choose the TVS, when to choose the MRI? What are the gestations where we have to choose? This investigation is a must question, please. And how do we manage this obstetric emergency? Best of luck from the entire team of RFA tutors. I will see you in the next guideline discussion. Thank you very much for being with us. See you again. Bye.